Hello, this is Dr. Adams, and today in the module on occlusion, which is titled Occlusion number 6, we wish to pick up where we left off quite a while back in the curriculum and finish discussing part 1 of the Gestalt of Occlusion, which, if you remember, is the physiology of occlusion, or in simple terms, the way that the mandible and maxilla and the temporal mandibular joints will function in normal health. Now, this particular module and tape and the slides which we will show are designed to go along with and to implement certain things which we have in the textbook. Now, the reading, which will be in the complete module, says Chapter 4 in the textbook. Specifically, we'll be talking about things in the book from page 77 through the end of Chapter 4. Again, the material here is meant to amplify and enlarge upon and hopefully clarify certain things in the book. Other things in the book which I feel are presented very well we'll either not touch upon at all or we'll touch upon very briefly. Now, if we look at the title card, we'll have an idea of what we will be looking at and discussing today. We want to talk about the influence of mandibular movements upon occlusal morphology. This will be the first subject. Then we wish to talk about a very vital and important clinical subject, and that is occlusal stability, stability of the dentition following any type of an occlusal procedure, be it a filling or grinding on the teeth or what have you. We'll then talk about the various types of occlusion and finally finish up with a subject entitled Tactile Sensibility and Occlusal Forces. So, the very first thing we wish to get into is mandibular movements and occlusal morphology. Now, if you'll take a look at me, if you'll remember in the earlier module on occlusion, we discussed Bennett movement and Bennett shift. And if you remember, I said that you can feel this and experience it yourself in your own masticatory system by simply placing the palm of one hand on the angle of the mandible like so. Do the same thing on the other side, and if you just wet your lips and let your jaws relax as you push this way and this way and this way, you can feel how the mandible will have a bodily shift to the left and to the right. And we discussed the importance of this, the Bennett angle and the Bennett shift. Now what we wish to discuss is the role and the influence of the degree and the nature and the amount of Bennett shift in relationship to the occlusal anatomy of teeth and restorations, specifically the placement of ridges and grooves. So to do this, what you can do to understand, you can put your teeth together and do basically the same thing. Push your jaw to one side and push your jaw to the other side. And then the rather complex subject which we'll be discussing in just a moment should make more sense. Because as you or your patients are masticating, if they have food in their mouth, they don't merely open and close like so, but they usually move their mandible in a rather elliptical pattern, either to one side or the other or to both sides. And as this happens, teeth do come together and teeth do contact each other and rub together or function one against the other. Therefore, it is important that as the jaw goes this way and that way, the ridge and groove placement of the restoration in relationship to the Bennett shift is quite important. You can either place ridges and grooves so that you have an atraumatic, smooth moving mandible against maxillary teeth, or you can place your ridges and grooves and subsequently your cusps in the wrong place. Now, before we get into this, you might say in a philosophical basis, which is then applied directly to the clinic, if you have a patient who is normal and healthy, is this important, assuming that you have just one restoration to replace, say a simple amalgam or a gold inlay or something? The answer is no. We do not recommend that the dentist prophylactically go in and grind teeth to place ridges and grooves, assuming that the periodontium, the muscles, the joints, etc. are healthy. This does become important when you, the dentist, are interested in replacing an extensive number of tooth surfaces, and when the patient has something wrong, some pathology or dysfunction in the masticatory system, be this missing teeth, drifted teeth, extruded teeth, periodontal disease, and all of the other problems which we will get into in the subsequent module entitled Occlusion VII, or the pathology or dysfunction of the masticatory system. Again, the important thing is that if a patient is healthy, if there's nothing wrong with him, although his ridge and groove patterns do not fit this rather rigid textbook criteria, we do not recommend going in and changing things around. It's an entirely different situation if the patient does present with some problems and needs restorative work as part of his therapy. In that case, then, it is incumbent and necessary upon you, the dentist, to place the ridges and grooves, or in a broader sense, to develop functional dental anatomy to provide that patient with the best possible function of the masticatory system. So if we'll now go to the first slide, we'll begin discussing the influence and the effect of mandibular movements upon the occlusal anatomy. Now, this first picture, as you will remember, we finished up with, I believe, in the previous module on occlusion. And this particular diagram and slide taken from the textbook illustrates the effect of what happens if the mandible is moved to the patient's right side, the left side on the screen. We first of all look and see what would happen in the condyle on that side, and called the working side condyle, and then look at the opposite side, or the balancing side condyle. Now, as the patient moves the mandible to the right side, the left side of the screen, we see a number of possibilities that could occur. 3 of them are illustrated on this slide. As the mandible moves from this point, entitled W1, out to W2, there are numerous possibilities. This area here is shown up down here, W1 being 1 point. W2 can be any one of a number of points in a 60-degree arc. In other words, as the mandible moves to the right side, the working side condyle, due to the anatomy of the glenoid fossa on the right side, this condyle may come laterally and anteriorly or protrusively, shown up on the slide as LP, latero-protrusive. The mandible may go straight laterally along a path like so, entitled SL, straight lateral. Or, depending upon the distal or posterior aspect of the lateral lip of the glenoid fossa, that condyle could retrude like so, shown here LR, lateral retrusion. Now, studies on various people have shown that the arc from a lateral retrusion to a lateral protrusion could be anywhere along a 60-degree arc. Now, what is not shown on this slide is that the same thing may occur in a vertical direction. This diagram is illustrating a horizontal illustration. That is, if you were looking straight down upon the skull and the condyles and the entire mandible. If you were to look frontally, the same thing can happen. That is, that the condyle could go straight laterally, or it could go laterally and could go superiorly or upwards, or the condyle could go laterally, and due to the lateral lip of the glenoid fossa, that condyle could drop down. Well, we don't have a slide on this to show today. It is illustrated in the textbook. And so while this is in a horizontal plane, you will have the same type of phenomenon in a vertical plane. Again, that is, the condyle can go laterally and superiorly. It could go straight laterally, or it could go laterally and inferiorly. Again, this is governed and determined by the anatomy of the glenoid fossa. And again, this is in a 60-degree arc, so if you put the 2 arcs together, you will end up with a 60-degree cone of possible working side condylar movement. Now, along with the working side, you always have to think in terms of what happens on the other side of the U-shaped bone called the mandible. And this is what we call the balancing or the non-working side condyle. Now, the balancing side condyle will move from a point C in centric occlusion and it will move downwards, forwards, and inwards, as is shown here. However, the path that it takes from one point to another point, illustrated in the enlargement here, C to B, the path it takes from here to here will be governed a great deal by the anatomy of the medial wall of the glenoid fossa on this side. And again, the way that this will move will have a great influence upon your anatomy in your restorations, specifically the placement of the ridges and the groove patterns. Now, in a semi-adjustable articulator, which at the present time you are not using, you would take a measurement in a wax or a plaster recording at point C, which is centric occlusion. You would then have the patient move his mandible to the right side and take another registration of the bite. This would register the point B. In a semi-adjustable articulator similar to a dentatus, a Hanau articulator, a whip mix, there are numerous ones on the market, you would be able to accurately record point C and point B, but you would not be able to record the path from C to B. On a semi-adjustable articulator, then, all you would be able to do would be to connect these 2 points with a straight line, which is the dotted line shown here. Sometimes this will work effectively and sometimes it won't. It will depend again on the anatomy of the medial wall of the glenoid fossa, which determines the movement path of the balancing or non-working side condyle. This illustration down here happens to represent a pantographic tracing, one of the tracing tables. And as this tracing shows, the balancing side condyle in this illustration would not move straight out like this, but it would have a rather definite, immediate Bennett shift, as you see here, and it would come down along a line like this. The importance of this clinically, we will again emphasize later, but the importance right now is that if you did not take this path of balancing side condyle movement into consideration, if you were doing restorations in this area, it would be quite easy in your cast restoration to place a balancing interference. That is a large area on the cast gold restoration which would create interferences. If you had a pantographic tracing and a fully adjustable articulator, it would copy, and then you could then transfer this in the laboratory to something meaningful, in that you would understand that this is the pathway of the condyle and be able to relate that to the anatomy of the occlusal surfaces. Now, the next slide that we see is taken from your textbook, and this illustrates the influence of the intercondylar distance upon the ridge and groove placement of your restorations. They show 3 examples here, A, B, and C. This shows a condyle on one side, and of course this condyle here would match up with it. Then illustration A shows the influence of a great intercondylar distance, the distance from here to here, upon the ridge and groove placement. This shows a mandibular tooth and a maxillary tooth, down here, maxillary tooth. Now, what this illustrates is that if you have a great intercondylar distance, then the ridge and groove placement on the mandibular teeth must be more distal. If you look at B, which would be a medium amount of intercondylar distance, on the lower it would be slightly mesial, on the upper it would be slightly distal. If you look at a narrow intercondylar distance, example C, if you look down here, you can obviously see that your ridge and groove placement with a smaller intercondylar distance would be more mesial on the lowers and more distal in the maxillary teeth. The next thing that we wish to illustrate, this diagram, again from the textbook, is a diagram in the horizontal plane. In other words, back in here you are looking down into the anatomy of the glenoid fossa, and imagine how this would affect the condyles as you move one side to the other. And what they wish to illustrate here is that the greater the amount of Bennett, the influence of the amount of Bennett shift, either a great Bennett shift or no Bennett shift. Now, a great Bennett shift is illustrated by this line here, point small letter C. If you had no Bennett shift at all, then the tracing would be along this line A. And if you had an intermediate amount of Bennett shift, not too great at the beginning, but ending up fairly far out, this was the point B. And of course, these letters down here would then correspond with the amount of Bennett shift. What they're trying to illustrate is that the greater the amount of Bennett shift, the more mesial must you place your ridges and grooves in the mandibular teeth, and the more distal in the maxillary teeth. Something else which they do not illustrate here, and that is that the greater the amount of Bennett shift, say in example C here, then you must make your corresponding cusp height less in relationship to the central groove. With a greater amount of Bennett shift, you cannot get away with real steep cuspal anatomy with real deep grooves. Something else that they wish to show here is that the greater the amount of Bennett shift, the greater must be the lingual concavity which you have in the maxillary anterior restorations. The next slide which we show is meant to illustrate the effect of the posterior wall, or specifically the lateral lip of the posterior wall of the glenoid fossa. Once again, this illustration is taken in a horizontal plane. That is, we are looking down upon the glenoid fossa. As I mentioned earlier, when you go laterally, the condyle on the working side could either go straight laterally, if that is the anatomy of the lateral lip of the posterior wall, or it could come laterally and protrusive, or laterally and retrusive. And again, these figures here, LR, etc., line up with the ridges and groove placement on the mandibular and maxillary teeth. Now, in essence, what they're saying here is that if you come lateral, if the condyle will come laterally and retrusive, LR, then your LR down here, your grooves must be placed more mesial on mandibular teeth, more distal on maxillary teeth. If you come downward, if you come forwards, lateral and protrusive, this has an effect upon the lingual concavity on the maxillary teeth. If the mandible, if the condyle, and obviously subsequent to that the entire mandible, more specifically the mandibular incisors, if you come protrusively, then you must have a greater lingual concavity in any maxillary anterior restoration to allow for the mandibular teeth to swing through this area as the mandible comes laterally. To follow the example through, if the condyle went laterally and retrusively, then the mandibular incisors would follow a path like that, and then you could get away with less of a lingual concavity on the maxillary anterior teeth. Now, the next slide, again taken from the book, this time illustrates the influence of these factors in a vertical plane. To understand this, you now imagine that you are looking straight into the skull from the anterior aspect. And as I mentioned earlier, we have three possibilities here. As the mandible comes laterally in a Bennett shift, the W refers to the working side, the B to the balancing side. In this case, we have three possibilities. Again, due to the glenoid fossa, the working side condyle may come straight laterally like so. Or, if the anatomy of the joint dictates, that condyle may come laterally and inferiorly. Or there may be little or no lateral lip, in which case, as the condyle comes laterally, it will go up like so. Now, this has a definite influence upon the cusp height, not only on the working side, but on the balancing side. And you can follow this. The LI being laterally and inferiorly would follow through here and here. In simple terms, if the working side condyle drops down as it goes into working side excursions, you can, if you wish, have greater cusp height on the buccal cusps of the maxillary posterior teeth on that side. At the same time, you may have greater cusp height of the lingual cusps on the balancing side. Now, why this is important is that if you were to have steep cuspal anatomy as shown by this line LI and LI, if you happen to get that type of cuspal anatomy and have a condyle which instead of coming this path would follow this path, you can see the path that the mandibular buccal cusp here and here would follow, in which case you would have a working side interference here in your cast restoration, a working side interference, and over here you would have a balancing side interference. Either one of these things being not desirable, particularly when the patient has had dental work to restore their teeth and their occlusions. Now, along with that, this following picture, again taken from the textbook, shows the influence of the concavity of the maxillary anterior teeth in relationship to the way that that condyle would move. In other words, a straight lateral would be like so. If the condyle would go laterally and inferiorly, this would be the path of the mandibular incisor against the lingual surface of the maxillary incisor. And again, I think you can see it's rather a simple problem of solid geometry or three-dimensional geometry of how various aspects of the horseshoe-shaped mandible can affect your occlusal anatomy. There is something else which is of importance, and that is the role of the medial wall of the glenoid fossa upon your cusp height, and that is seen in this diagram here. And this has to do with whether you have very little Bennett shift, as shown here in Figure A, or if you have a tremendous amount of Bennett shift, as shown in Figure C. Very simply, as the patient goes to the right side, the condyle on this side, the balancing condyle, could move along a path like this or this. Now, in clinical terms, this again is important in the shape and the steepness of the lingual cusp on the balancing side, represented by B, or on the working side, represented by W. Again, very simply, if you have very little Bennett shift and the condyle drops down rather immediately as you go to this side, then you can get away with steeper cusps on the balancing and on the working side. However, if you have a great amount of Bennett shift, or another way to put it, a fair amount of slop or play of the condyle in the glenoid fossa, you then cannot build steep cusps, and you must have rather wide central groove areas to permit the mandibular cusp to move this way. Again, this movement is directly related to this. In this particular instance, the medial wall of the glenoid fossa. Remember, a few moments ago we talked about the influence of the lateral wall, and you must keep both in mind at all times. This is a different illustration to make the point that if you have no Bennett shift and you come down point A, the mandibular cusp tip will follow a path like this. You can then make steep anatomy and eliminate or prevent balancing interference. Again, if the condyle comes like so on your pantographic tracing, you know then that you must have an entirely different form to the ridges, grooves, and inclined planes, and in this instance, the cusp height in relationship to the condylar anatomy. Now, this again is an old slide which we showed in the previous module on occlusion. The importance of this that we meant to bring out was the delicate interplay between the 5 factors of occlusion, entitled either the Thielemann articulation formula or the Hanau-Quint. And again, very briefly to review, we have the condylar guidance, the angle of the condylar inclination, we have the angle of incisal guidance, we have the plane of occlusion, the curve of Spee, and the individual cusp height or angle of the cusp. And this particular formula here is designed to show the interplay one to another. Again, I stressed the point that in clinical dentistry we can affect 1 or 4 of these things. We cannot, short of extremely drastic procedures which are never warranted, we cannot alter or change this factor here, the condylar guidance factor. If you're doing one or two restorations, you can virtually do nothing about the plane of occlusion or the curve of Spee, but you can change the cusp angle. In some cases, you can change the curve of Spee and the plane of occlusion, and if you are restoring 6 anterior teeth, either upper or lower, or if it's 12 anterior teeth, then you must pay attention to incisal guidance and understand the role of incisal guidance in relationship to this thing, the entire back end. Now, this is meant as a slight and a brief review for the next slide taken out of Chapter 4 in the textbook. It's a rather complicated slide, and the best way to understand this would be to read the book on this, which would be on page 83. But the main point of this diagram and illustration is to show the relationship between the curve of Spee and the angle of the eminentia, or the condylar guidance, and how these factors have a definite interplay one against the other. Again, keep in mind that the angle of the eminentia, or the condylar inclination, you cannot change. But the angle of the cusps can be changed within certain limits depending upon the incisal guidance and the angle of the condyle. Now, this particular picture is also taken from the textbook, and it is now meant to illustrate the influence of a bad occlusion. As we see down here, this is the horizontal plane rhomboidal configuration which we see of the border movements of the mandible. This point here, CR, being centric relation, this point here being centric occlusion. We wish to have centric occlusion, or the intercuspal position, be in the mid-sagittal plane. That is, that the mandible is in the mid-sagittal plane of the skull when the teeth come together. If the teeth do not intercuspate to the maximum at a point like this, you will then end up, as the illustration shows, with a centric occlusion or intercuspal position which is off the midline. The delicate interplay between the anatomy and the condyles is shown here and discussed in the textbook. I'll just very briefly summarize this. That is that whenever the centric occlusion or intercuspal position is such that the mandible is off the mid-sagittal plane, as illustrated here, this is almost always a direct result of the intercuspation of the posterior teeth, as illustrated here, the upper teeth against the lower teeth. And again, this is almost always a direct function of the ridge and groove placement and the subsequent inclined plane placement of one tooth in relationship to another tooth. If the ridge and groove placement and inclined plane placement, one tooth against another tooth, is not correct, these inclined planes will force the mandible off the mid-sagittal plane to one side in an attempt to get the teeth to mesh at their maximum intercuspation. As this occurs, as is shown here, you then have the balancing side condyle, which will be pulled downwards, forwards, and inwards, and the working side condyle will be pushed laterally, and again either superiorly, inferiorly, posteriorly, or anteriorly, anything along that 60-degree cone. Once this happens, this is purely a functional result of the way the teeth come together. To get the teeth together, the mandible and the condyles have to go through this kind of a contortion to get the teeth together. To get the teeth there time after time after time is a function of neuromuscular physiology. In simple terms, the muscles on one side must contract in a strained and abnormal manner, pulling this condyle forwards, downwards, and inwards, and moving this one laterally, just to get the teeth together. This then sets up the entire program for us to get into pathology and illness, either in the muscles or in the joint or in the teeth. Now then, if we can look at the next title card, the next important thing to discuss in relationship to this entire business is occlusal stability. That is, how are the teeth maintained stable one to another in the same arch and one against another in the opposing arch. One of the keystones to success in a healthy physiologic functional occlusion is occlusal stability. This is important not only in doing simple, small restorations, but all the way up the line to the ultimate, and that would be a full mouth reconstruction case. The key to success of good occlusion and the key to health of the masticatory system is occlusal stability. So if we'll go back to the slides now, the first slide which we have is taken from the Journal of the American Dental Association in 1963, an article published by a couple of doctors by the name of Dempster, Adams, and Duddles, and I'm not the Adams, I'm not related to the gentleman that did this work. But when we talk about occlusal stability, the first thing that we need to understand is the nature and the inclination of the various teeth. In this instance, you see a maxillary aspect of a skull. And what they have done is drawn lines parallel to the long axis of the various teeth. And in a lateral aspect, you can see how the axis of these teeth will vary from the central incisor all the way around to the maxillary third molar, this being in a mid-sagittal plane. But then you have to also look at this illustration head-on to the maxilla, and again you can see the vertical inclination of the teeth in this plane, and it's quite obvious that as we come posteriorly around the side that there is more and more of a buccal inclination to the vertical axis of these teeth. Now the next slide is taken from the same article and illustrates the same thing on mandibular teeth. If we look first from a lateral aspect, if you wish, the axis in the sagittal plane, you can see that there is some variation in the vertical axis or inclination of healthy teeth from the central incisor to the lateral to the cuspid to the premolars and finally around to the third molar. Probably more important in understanding is if you look at the frontal plane looking straight on at the mandible, you can see that the mandibular central incisors are practically vertical. But as we go around the arch back to the first, second, and third molar, you see that we have a naturally occurring lingual inclination to these teeth, as illustrated here. Now, the point is brought home if you take a look at plaster models, which are intercuspated, and then if you take a model grinder and grind these models, say, through to some aspect of the molars, as in this case the maxillary mandibular molars lying in the same vertical plane, but our centric forces are primarily on the mandibular buccal cusp and the maxillary central groove and the maxillary lingual cusp and the mandibular central groove. And if you draw a line in this plane here, you can see that there is a difference between the vertical axis and how these things would contact. Now, the importance of this is brought home rather well in this illustration, which is copied out of your textbook on page 97. The main point that they wish to get across in this is that maxillary and mandibular anterior teeth have one type of intercuspal angulation. As you get to the first premolar, it can be different. The second premolar, first, second, and third molars. A thorough comprehension and understanding of this concept is important when we get to talking about how to get stability in dental restorations. For instance, you might wish to have one type of occlusal contact if the teeth are in this vertical relationship, whereas you might wish to have an entirely different occlusal form to your restoration for teeth which are in this form here. In stability of the dentition, the main thing which we wish to have is the forces of centric occlusion to be directed axially, that is, up the root of the tooth. If the tooth is strictly vertical like this, it is quite easy to do that. On the other hand, if you have a third molar relationship like this, with the mandibular third molar having a lingual inclination and the maxillary third molar having a buccal inclination, then sometimes after you do your restoration, you then must alter the occlusal morphology somewhat to obtain stability. Something else of importance, and we will talk about this a little later on in this tape, something else of importance is whether or not the tooth is well anchored and stable in the arch, or whether it has suffered the ravages of periodontal disease and has a reduced amount of alveolar support. This has a lot to do with occlusal stability. As you see here, this is a picture from a textbook illustrating primary occlusal traumatism. The main aspect of primary occlusal traumatism are two things. Number one, that we have a normal or near normal amount of alveolar bone housing in which the tooth is placed. Little or no periodontal disease, little or no bone resorption. In this case, if this tooth were to suffer from occlusal trauma, it would have to be, as illustrated here, number 3, a rather heavy force. As it says down here, the applied force to this tooth is greater than normal, and the applied force is almost always in a non-axial direction. As you can see here, the result of this force would tip the tooth around the point of rotation, causing us troubles up here and down here with pressure and tension in this region and this region. This then is the concept of primary occlusal trauma. Again, in primary occlusal trauma, number 1, you have a healthy amount of supporting bone, and number 2, 3 on the slide, you have an excessive amount of force, not in an axial direction, but in an angular direction. Now, as opposed to this, you have the concept of secondary occlusal traumatism. Again, the two factors involved. Number 1, there is a less than normal amount of alveolar bone housing to support the tooth. In simple terms, this tooth has suffered the ravages of periodontal disease and periodontal resorption. In this illustration, there's been successful periodontal therapy and no pocket formation. But by this time, while the remaining periodontium is healthy, there is not that much remaining periodontium, and strictly all by itself, the tooth may be loose or mobile. And point number 3 now is the applied force is less than the normal amount of force, as illustrated by a very small arrow. But again, in this case, the force is applied to the tooth not in an axial direction, but in a non-axial direction. So therefore, again, the difference between primary trauma and secondary trauma, the amount of force applied and the amount of periodontal support. If we were to take this amount of force as illustrated here and apply this to the previous tooth, the tooth with a normal amount of support, there would be no mobility in the tooth, or the other way around, the tooth would be stable and would be all right. But in this case, even with subnormal forces, the tooth is made mobile, is made unstable, and will tend to shift around in the arch. To get ahead of the story a little bit, the role of occlusion in a patient with periodontal disease. Very simply, occlusion becomes more and more important as the amount of alveolar bone anchoring the tooth decreases. The less the bone, the more important the occlusion. Again, the concept of primary and secondary occlusal traumatism in relationship to stability of the dentition. Well, how do we relate this clinically in practical terms? Well, in a clinical sense, in therapy, there are basically 2 ways to obtain stability. Again, stability means that the resultant forces of occlusion in centric occlusion and or centric relation, but the resultant forces of centric biting will be directed axially along the long axis of the tooth. You can do this one of 2 ways. On the left is illustrated the technique of tripodization. And again, this is a 2-dimensional diagram, which is rather difficult to follow, but there would be a 3rd inclined plane around this cusp and around this cusp. And with 3 inclined planes, the vectors of forces can be such that the resultant direction of force is axial. There are certain schools of thought in restorative dentistry that say that this is the way it should be done, for the simple reason that this is nature's normal way of having occlusal contacts in the newly erupted, non-carious, non-restored, and unworn dentition. In other words, in your teenagers without caries, etc. This is the normal type of occlusal relationship which you see. Therefore, again, certain schools of thought in restorative dentistry attempt to slavishly reproduce this. As long as the result is that the forces of occlusion are axial, that's fine. In a practical sense for you or for me as clinical dentists, this is an extremely difficult technique to follow and to carry through with. So therefore, clinical dentistry has designed a second technique, and that is this one. And we call this the mortar-pestle type or cusp fossa type of occlusion when we are doing restorative dentistry. It is a much simpler and easier way to get the same desired result, and that is that when the patient bites together at centric occlusion and or centric relation, that the resultant forces of biting in centric are directed axially. The only way to obtain occlusal stability is to get the occlusal forces directed axially. Again, two ways. One, the cusp fossa way, or called the mortar and pestle, or tripodization like so. Again, in simple clinical terms of how to help patients, this is much easier to do than this. This is also acceptable. In the clinic and in subsequent modules in occlusion, the technique that we advocate and teach here at the University of Texas is this technique. But again, it is incumbent upon us to inform you as students that there is another technique. We do not teach this simply because it is too difficult to get across at this aspect in your career. Now, in clinical terms, there is something else of importance in the stability of the dentition, and that is when you have a high restoration or something like this. These red lines here illustrate an old-fashioned, time-honored technique which we call spot grinding. That is, you put some blue articulating paper in a patient's mouth if they have a high filling. Assume this were a new crown or a new crown here. And then the dentist would either grind or reduce this area or this area or this area, or any combination of two or all three of these areas in an attempt, number one, to unlock the occlusion, and number two, to reduce a high filling. This, again, is the time-honored technique of spot grinding. If done on one tooth or perhaps two teeth, sometimes it is all right to do. But if you do it on three teeth or more, and in this case even on two teeth, it is an undesirable technique because we lead to subsequent instability of the dentition. An unstable tooth or unstable teeth will then begin to drift and shift in the arches until they obtain a more stable contact. Now, what would happen in a dentition if you were to do this? You would eliminate contact here and here, and you would eliminate some working side contact here. These teeth would then virtually not contact at all except on this inclined plane area here, perhaps here and here. This would not be an effective tripodization, as mentioned earlier. These would be haphazard inclined plane contacts. The net result of something like this almost invariably is that the upper tooth will drift downwards and buccally, and the upper tooth will drift upwards into the lingual. As a net result of this, you will get movement of the teeth until they become more stable, but in the net result of this, you may have undesirable contact in this region, which would then be considered a balancing side interference. If this tooth were to tilt far enough this way in relationship to the maxillary tooth, you could then end up with a working side prematurity in this area. Now, in practical terms, in the clinic, as you are working on patients, the simple way to obtain stability, once again, is to have the forces of centric relation and centric occlusion directed axially. In this illustration, you see this could be either a simple class 1 amalgam, or it could be an MOD inlay or onlay in gold or anything in between. But the point is that in everyday restorative dentistry, we should attempt to obtain stability. The best way to do that, in the simplest way, being to have the maxillary cusp land in a small, flat, level area in the restoration. To follow through with this, if the restoration were to include a cusp tip, you should have the cusp tip in gold or amalgam land in a small level area in the central fossa of the opposing teeth. Now, in the anterior teeth, we have a similar problem with stability, as is illustrated here with incisors. This is particularly relating to the technique of putting anterior crowns on teeth, either full ceramic crowns, porcelain jacket crowns, or acrylic crowns, or as is illustrated here, a porcelain fused gold Ceramco type of anterior tooth. Quite often dentists will get in trouble by reducing a natural tooth which had an occlusal relationship similar to this. They then choose to put in a porcelain, acrylic, or porcelain baked to gold restoration. We call these torpedo crowns because if you look cross-section at them, it looks pretty much like a torpedo ready to go out of the tube. This type of restoration is unstable, and the net result of putting this type of restoration in many mouths, particularly in Angles Class 1 or an Angles Class 2 type of dentition, the lower anterior teeth will strike unfavorably against the upper anterior teeth. The net resultant vector of force will be in a direction like this, which could be highly unfavorable to the dentition, resulting in mobility of the anterior teeth. The thing which we wish to obtain in such a situation is what we call a long centric cingulum, and it does not have to be anywhere near as long as the illustration here. But the main point is, for stability on anterior restorations, if the lower anterior teeth contact the maxillary anterior teeth, we need to have a small seat area so that the resultant forces are in rather much an axial direction, and we get then resultant stability of the dentition. You can do this by grinding, as is illustrated in this model, or this slide. If the anterior teeth are so and the resultant forces are labial like so, the next step would be to take red or blue articulating paper to mark these contacts, and then, as illustrated here, to reduce the labial aspect of the mandibular incisors so that when you mark once again, the force at centric occlusion will be on the mandibular incisal edge, as shown here. You would then remark the teeth, take something like a small inverted cone, greenstone or whitestone, and then, this is again greatly over-exaggerated on the slide. In the dentition it would not have to be this big, but you would then place a very, very small seat on the lingual aspect of the maxillary anterior teeth. Then the resultant forces when you tap together would be such: the mandibular incisal edge would land in a small seat. The artist in this illustration was a little over-exuberant. The direction of force would not be directly up the root, but would be much more favorable in a direction like this than was the direction of forces in this instance over here. Now, from there we can begin to understand better what we're talking about when we discuss the criteria for optimal occlusion. The first thing we wish to have is stability in centric, with eccentric forces of occlusion directed axially. The second thing that we wish to have are smooth, unimpeded, and multi-directional movements of the mandible to the left, to the right, into straight protrusive, and any other path along that direction. And again, whether or not these are smooth and unimpeded or not will depend greatly upon the contour and the form of the dental restorations, as we discussed previously, in relationship to the anatomy and the movements of the mandible, the condyle in relationship to the glenoid fossa. Now, the next thing that we wish to discuss, and we won't bother with a title card on this, are the various types of occlusions which are discussed in the textbook and which you will see discussed in dental journals and at dental meetings, etc. We have what we call a functional occlusion. This we have discussed before. That is, how do the lower teeth relate to the upper teeth in various movements of the mandible? How do teeth come together in contact? Where, why, and when do they contact? This is the essence of good occlusion, how and when teeth come together. Number two, the concept of an ideal occlusion has changed considerably. And as is discussed in your textbook now, an ideal occlusion is one in which there is little or no neuromuscular adaptation to the teeth. That is, that the higher centers of the central nervous system do not need to modify, govern, and influence the way the muscles of mastication contract to get the teeth together in centric relation, centric occlusion, and all of the lateral excursions. Number three, a morphologic occlusion, on the other hand, deals with the way the teeth are physically lined up. This is what the subject or the science of orthodontics is all about. Number four, a normal occlusion is what basically you and I and most of your patients would present with. What we mean here is there may be centric relation prematurities, difficulty in the mandible moving in some direction, but there is no pathology in the masticatory system. With an overriding influence of the central and higher centers in the central nervous system, small prematurities in the dentition are avoided completely, and the patient can chew and get along just fine. Number five, a physiologic occlusion is basically the same thing as a normal occlusion. Number six, a pathogenic occlusion would be an occlusion in which there are these prematurities that we mentioned. This type of an occlusion has the potential for creating trouble, but at the present time the patient has been able to adapt to the occlusion, physiologic adaptation, and there is no breakdown or dysfunction or pathology. Lastly, we discuss traumatic occlusion, and as I mentioned earlier, under stability we have gone through the various types of traumatic occlusion, either primary or secondary traumatic occlusion. Now, the next thing that we wish to talk about is tactile sensibility and occlusal forces. Tactile sensibility and occlusal forces are very important in understanding the difference between a physiologic occlusion or a normal occlusion and a pathologic or dysfunctional occlusion. Now, first of all, we can talk about tactile sensibility, and in simple terms, that is, what is the sensibility of the periodontal ligament or periodontal membrane around teeth? How sensitive are these factors? Well, again, I refer you to the textbook Chapter 4 for a greater discussion on this. We just wish to touch on the highlights. In simple terms, in the natural dentition, opposing teeth can detect or perceive something as small or as thin in diameter as 0.01 millimeters, far, far less than the diameter of a human hair. In the artificial dentition or full dentures, similar studies have shown that the thickness which this membrane underlying dentures can detect is somewhere in the range of 0.02 millimeters. Now, in relationship to this, we then need to discuss occlusal forces. In the range of normal function, the greatest amount of force applied upon the tooth is exerted at the time of swallowing. The normal range of occlusal forces in mastication and swallowing is usually no greater than 12.5 kilograms or somewhere in the neighborhood of less than 30 pounds. Now, again, research has shown that if you put in a restoration, such as an inlay, onlay, or gold crown, or a large amalgam restoration, and if that restoration is as much as 1/2 millimeter high, I should say as little as 1/2 millimeter high, the occlusal load or the occlusal force upon that tooth with a high restoration is doubled. And this then can set up the forces to create an awful lot of problems. Now, another thing is, what is the normal amount of force which the periodontal membrane can detect. Well, the average amount of force that the periodontal membrane can detect is approximately 1.5 grams. However, many people with normal dentitions will be able to detect something in the range of 600 milligrams. The importance of all this is that if you have a high restoration in one or more positions, quite often neuromuscular physiology will take over. The muscles will contract in a slightly different manner so that the patient will not bang those teeth together and will not be able to detect this particular thing in your dental chair. However, when he goes home and goes to sleep, then in comes parafunction or bruxism, and the patient can bang the devil out of those teeth. Briefly to review, we discussed the influence of occlusal morphology and mandibular movements, their role in occlusal stability, the various types of occlusion, and lastly, the influence and the role of tactile sensibility and occlusal forces upon the entire function of the masticatory system.